Let's get back to this. I got cut off in the middle of there. I think I was starting with the volvulus, which is the twisting of the intestines. Okay, so if you look down here, then the intestines, they literally just get twisted around. I think I did mention this, by the way. When the child is going through embryogenesis, or through the final stages of being born, the intestines actually come out of the body, and then they do some things, and then they kind of rotate back in. Well, sometimes that doesn't work right, and you end up with twisted intestines, or malrotation and development. Same thing, right? And that cuts off blood supply, obviously, because there's blood in there, and vasculature, arteries, veins, that sort of thing. So it's obviously, as you can see, this is a problem. Yes, it is both acute, happens really fast, and it's severe. You lose that blood supply for very long, and it causes permanent damage and death to that tissue beyond that. Okay, what happens is all of a sudden the baby starts bilious vomiting, is what they say, and abdominal pain or colic. Almost all the time they get this projectile vomiting with bile in it, and green projectile vomiting basically is what we're talking about. And of course it takes immediate surgery to go in there and untwist that. Okay, so it's one of those things where you get some pretty fast signs, pretty apparent signs of what's going on real fast. Okay, clinical, you can obviously see it on an x-ray on that twisting. CT would do it, ultrasound even, so you can catch it a lot of different ways. The current jelly is what we're talking about, coming out of the stool. Well, actually, that current jelly, that's not even talking about this. That was talking about the intussusception. Anyway, moving on. Back to intussusception. Okay, I can't remember if I talked about this, so I'll mention it again. Again, we're back to the intussusception for a second here. With the barium enema, you go ahead and you put that up there so that you can view it on a film, but it may actually fix the problem too with just the pure pressure of that coming up there. If not, air embolisms also have pretty good success with clearing out the intussusception too, or telescoping. Okay, let's look at this little video here. This is a volvulus, or a twisting, and oops. I need to go ahead and turn this sound down because that was not working correctly. But look at how big that intestine is. It's filled up with gas and bloating, and a thing that looks like it might explode. So you can see where that is definitely a medical emergency, to have something like this intestinal volvulus inside. It's just waiting for it to blow up, and these surgeons are having a little bit of a trouble here trying to get that untwisted. As you can see, it's a bit of a Rubik's cube there. Surgery, look at that in there where it's definitely all twisted, and they're trying to figure out how in the world do we get that untwisted, especially when it's all ballooned up like that. Obviously a problem. Yes? Okay. Looks like the video's just about over here. Not that they're going to show the finishing product of it, and we'll move on to the next. Okay? Talk about Hirschsprungs disease, or congenital megacolon. The reason they call it that, Hirschsprungs or congenital megacolon, actually I'm sure that Hirschsprungs is named after somebody, but the congenital megacolon part is just because it's congenital, you're born with it, and it is a mega, huge, really big colon. And what's going on here is, as we've mentioned before throughout the course, the intestines, they have their own nervous system. So what's happening here is you're missing some ganglion cells, or part of the nervous system in the intestines, and because of that, the intestines don't stay innervated very well. I'm going to show you the picture here so we can kind of talk about here. But this is your normal colon, right? There's your ascending, trans, and descending colon and sigmoid down here. Well, here's what we're talking about is, you notice the size of this descending colon here. With Hirschsprungs, you don't have the nervous system to hold in the tenseness. What word am I looking for? You don't really have the integrity to be able to hold that firm and So when food comes down there, it just kind of piles up, piles up, piles up, and all you get is a little bit of squeezing through, so they have like ribbon-like stools coming out. And that's a pretty good indicator of, maybe you have this Hirschsprungs or congenital megacolon going on. But as you can see, this gets really, really big, and we just saw in that volvulus how having large colons is not necessarily the best thing that you ever want to have, right? So the malformation of the parasympathetic nervous system, and 80% again is down at that rectal end. Okay, it can be in other places, but most of the time we're talking there. Inherited, I don't know, quite frankly, if it's actually inherited. I don't remember reading anything anywhere. It's on page 942 of the book. If did I say 942? I did. 942 of the book. So you can certainly go back and look that up to find out. I'm going to go ahead and kind of page through my book here while I'm talking to you here to see if I can find that. But this is pretty common. In fact, the most common cause of colon obstruction in infants, which is not that infants have a whole lot of obstruction, but it would be the most common cause as far as that goes. Anyway, so signs and symptoms. What do you see? Well, delayed meconium stool at birth. All right, so the meconium stool is supposed to be, just a little greenish kind of stool that comes out because, the child throughout the entire last part of development is basically swallowing all of the, swallowing all of the amniotic fluid and getting nutrients and everything through that way, and everything's passing through the entire digestive system before it comes out the other end and gets recycled. Well, there is a meconium stool that that is supposed to be passed, right after birth. Anyway, so I already mentioned the ribbon-like stool, and okay, here we can have obviously a problem, because what's happening again is because you have that big old ballooned out colon, then you can have things getting in there and bacteria growing, and you can end up in toxic enterocolitis, and any kind of sepsis or something like that can lead to a fever, infection, and the symptoms that go along with that. How do we test it? The anorectal manometry, okay? And what that does, I think we mentioned the manometry before in different modules. Basically, you're testing muscle strength, and that's what this does. It specifically will test the nerve supply and muscle strength down there in the colon. Okay. Of course, you could see it, right? And with a rectal biopsy, you will know pretty fast that it's not around there. Okay, I did go back to the book on page 943 while I was trying to talk through this, and my phone was ringing and paging through the book at the same time. And what I've come up with the hereditary thing or inherited thing is they say that it's not known, but with the incidence in 1 in 5,000 and mostly in males, the only inherited part of it that they really seem to be aware of, at least in the book, is that's a question mark, because there seems to be a really high incidence of congenital megacolon in Down syndrome children. So I think there's still a question because of the chromosomal, obviously, Downs. There are certain forms of it that can be inherited, so that's why there's that. Okay. Anyway, it's our little picture. The artist has everywhere there's a little dot in the entire colon is a nervous system ganglion, or a gang of nerves, and if you can see here that it stops, so all of this does not have any nerves, or it could be across the entire transverse and descending in sigmoid colon too, but again 80% of the time it's just the descending in sigmoid colon that is the problem. Ready? Mekels diverticulum. Okay, Mekels diverticulum is kind of, well, it's like diverticulosis in an adult, except that this, if you notice, is in the small intestine. Okay, and this happens to be the most common congenital malformation of the GI tract, period. And what's happening here is you have gastric mucosal cells that are ectopic. They're not in the right place, and they get inside in these diverticuli, and it can cause a peptic ulcer, or it can cause bleeding, or, you know, most of the time, like it says down here, it's asymptomatic. But it is actually the most, well, like I said, the most common congenital malformation of the GI tract, but it's also the most common signs and symptom of this is actually painless rectal bleeding. So most of the time they either have no symptoms at all, or you just have a rectal bleeding that you have no idea on why that's really happening. Okay. They can test it with the radionucleotide I'm having trouble pronouncing things today. Scintigraphy. And they call it a Mekels scan. So it's just a very specific scan to look for it. Do I have a picture of that anywhere? No, I don't. I have a picture of the Mekels diverticulum. Again, it looks like a regular diverticulosis, but it's in a baby, and it's in the small intestine. Okay, here's our little repair of it. You don't know if you can really see that really well. Let me see what Prezi has to offer and zooming in. Okay, it blurs out the words, but if this up here is the diverticulum, and basically what they're doing is they're squeezing it off a little bit, and then they're going to cut it off and then tie it back up and close it back up, and you know, now it's not there anymore. So it's pretty mechanics, basically. You know, just cut it off, sew it back up. All right, look at something a little more interesting than that, and that is polycystic ovarian syndrome. This is very, very common, and when we're talking 1 out of 15 women, that is extremely common, right? So, most common hormonal disease of women at childbearing age. You notice there's a whole lot of most commons around here. If they break them up in that kind of detail, at childbearing age, you know, well, okay, that. Anyway, so it's a hormonal disease of women at childbearing age. Therefore, it is the most common. 1 out of 15 women. Sorry about that. What happens here is PCOS, polycystic ovarian syndrome, is a syndrome. Okay, in any syndromes, you have a whole bunch of signs and symptoms, as you can see down here. Okay, out of those signs and symptoms, to diagnose PCOS, the lady has to have at least 2 of these conditions. Okay, so you have, you know, few or no ovulatory menstrual cycles. You have to have elevated levels of androgens, and that's a huge one. The androgens have to be elevated, and these are the male hormones, so the testosterone, stenodione, anyway, DHEA, these are forms of testosterone here, androgens. So those are elevated in women, the male hormones, and polycystic ovaries have to be there also. So you have to have 2 of those 3. Okay, so the anovulation or very few menstrual cycles, elevated androgens, and polycystic ovaries. The other things are things that you tend to get. Okay. Now, a lot of women, in fact, quite a few of them, don't get all this. But virilization, you gain male traits. Maybe is that listed somewhere else here? I don't see it listed anywhere else. But you get hirsutism, or you get a lot of hair. Again, they don't necessarily have to, but PCOS is actually one of the leading causes of infertility in women, and this may be familial. Again, it may run in families. Back to the signs and symptoms here. If you look at some of these things, it kind of looks like metabolic syndrome a bit, where as the older they get, the more like metabolic syndrome you get with the insulin resistance and obesity and that sort of thing. Okay, you also find a lot of times PCOS in association with other endocrine disorders, like Cushing's disease or acromegaly, or just obesity. Could be from a hormonal disorder, and congenital adrenal hyperplasia, thyroid, and all sorts of different things. Ovarian tumors also. But what we're talking about here is polycystic ovarian. Okay, so that means that the ovaries are the main thing that are cystic here. If you, well, that's not what I was looking for. I'm looking for these. Okay, and if you look at these are the cysts that are growing on the ovaries. So what's happening is, again, 1 month from one ovary, 1 month from the other ovaries when the eggs are being released. Okay, so the egg, it gets released almost. So it kind of starts to, it's developing the follicle, the egg, and it kind of works its way out, and it starts to release, but it kind of sticks there and doesn't get to go anywhere. So then it kind of sticks there and it turns into a cyst, and then the next month the other ovary does it, and then the following month back to this ovary again, and pretty soon you have a pile of eggs that are turning into cysts because they're not actually being released anywhere. Okay, so back to our acanthosis nigricans. I didn't mention that. This has more to do with the insulin resistance that is tied more to the pre-diabetes or diabetes type 2. So you see the acanthosis nigricans, the really darkening of the skin in these ladies, whether they have diabetes or PCOS, and has the same symptoms along with it. Okay, because it's kind of like a metabolic syndrome. You get the hypertension, the hyperlipidemia, a lot of lipids in the blood, cholesterol as in. Okay, the non-alcoholic steatohepatitis or NASH that we saw way back long ago. Remember that fatty liver thing? Okay, isn't necessarily associated with, it's not caused as far as we know by obesity, but it seems to fit in the PCOS syndrome pretty well there. Okay, elevated CRP, which is C-reactive protein, indicates inflammation, and therefore you have inflammation, and it increases your risk for cardiovascular accidents or heart attacks. All right, so you test the hormones, you're going to find these high androgens. You can look at the cysts through ultrasound or CT, and you do need to rule out sources of hormone secretion, like tumors of something that is causing it. Okay, there's no cure. All you can really do is treat the symptoms with PCOS. And even though these ladies are supposed to be mostly infertile, clomiphene, things like that, actually has pretty good success with helping it so that they are not. Okay. Anything else I wanted to say on here? As far as other hormones, the FSH is usually low or below normal, and the LH is usually increased. Okay. I guess that's about all I wanted to go in on that. Okay. Alrighty, diabetes is pretty familiar, I think, to us. Actually, before I get into that, I need to break this off. This video is getting a bit long, and I'll start out with diabetes the next time.